Greetings, dear learners. We were learning cardiac poisons. We knew different cardiotoxic drugs and the plants. Under the cardiotoxic plants, we learned the details of tobacco, Nicotiana tabacum, foxglove, digitalis purpurea, white oleander, Nerium odorum, yellow oleander, that is Cerebra thivacea, and the society, that is Cerebra odolum. Today we shall be learning the remaining two plants, Cinchona alkaloids, that is quinine, and the Aconite. These were the plants that we learned yesterday: the tobacco plant, foxglove plant, Cerebra thivacea, that is yellow oleander, white oleander, and the Cerebra odolum. Now coming to the Cinchona alkaloids. The term Cinchona has the interesting origin. According to the tradition, the tree bark cured the wife of a Spanish viceroy of the Peru named Countess of Cinchon from the disease malaria. So the name of the plant arrived from there. Its genus belongs to the Rubiaceae family. As you can see in the picture, this can help to identify the plant. The bark that is obtained from the plant is dried and used for the medicinal and other purposes. The bark is dark brown in color. Basically, this bark contains the most of the alkaloids that is present in the cinchona. The bark of the tree contains the quinine and the laboratory alkaloids, and its D isomer is quinidine, which are used as an antiarrhythmic and as an antimalarial in some countries. Active principle in the plant is that the bark contains more than 20 different alkaloids, most importantly quinine. Other important alkaloids are dihydroquinine, quinidine, dihydroquinidine, cinchone, and cinchonidine. The mechanism of action of the cardiac toxins we already talked in the last class. On the similar line, this also causes myocardial sodium channel blockage, and by this it produces its toxic effects. Toxic effects of the Cinchona alkaloids are termed as synchronism. So, on the repeated therapeutic doses as well as on overdose results in a cluster of manifestations referred to as synchronism, which is characterized by: on mild exposure, it causes tinnitus, headache, nausea, and disturbed vision. On severe exposure, it causes vertigo, deafness, mydriasis, photophobia, diplopia, constricted visual fields, scotomata, blindness, that is referred to as quinine amblyopia, vomiting, diarrhea, abdominal pain, sweating, skin rash, hypoglycemia, and the cardiac arrhythmias. Rapid infusion of the quinine can cause severe hypotension. On potentially lethal dose, it can cause the delirium, coma, seizure, and the myocardial depression. Other features of the quinine toxicity are: fixed dilated pupil are seen frequently in children following quinine overdose. Following an overdose, onset of symptoms of oculotoxicity may vary from the few hours to a days or a more. There is a constriction of visual field that can progress to blindness with dilated non-reactive pupils. Central vision usually recovers first. Complete recovery of the vision may take several months. Pupils may remain dilated after the recovery of vision. Permanent visual deficit may remain there even after the cure. The cardiovascular effect typically occurs within the 8 hours of ingestion. SA node, atrioventricular, and his ventricular conduction delay may occur, resulting in significant QRS and QT interval prolongation. PR prolongation, ST depression, and T-wave inversion on ECG are seen. Ventricular fibrillation, ventricular tachycardia may also be the clinical presentation. Torsades pointis may lead to syncope. Hypotension occurs frequently following severe overdose. Hypokalemia may occur secondary to quinine-induced electrolyte fluxes. Hearing loss is reversible at therapeutic doses and occur in 20% of patients taking prolonged courses of about 200 to 300 mg daily. Sensorineural hearing loss is a common presentation that affects high frequencies initially. By the time losses at the conversational frequencies are noted, the hearing loss may be irreversible. Central nervous system toxicity seems to be more marked in children than the adults. Children frequently present with convulsions following an overdose. Hepatotoxicity with therapeutic quinine use has occurred within 24 hours of initiation, although onset generally occurs after 2 weeks of therapy. Hypoglycemia is also been reported. Hemolytic anemia may occur in patients with the G6PD deficiency. Immune mediated pancytopenia and coagulopathy may occur at therapeutic doses of the quinine. This may be associated with renal failure and the hemolytic uremic syndrome. Quinine can sometimes produce a hypersensitive reaction characterized by massive hemolysis, hemoglobinuria with passage of dark urine, anuria, and the renal failure. This all features combinedly called as the black water fever. That is one of the characteristic feature of the quinine toxicity. Particularly, this occurs usually during the course of the treatment of the falciparum malaria. Then the fatal dose of the Cinchona alkaloids are quinine it is 2 to 8 grams, quinidine it is 4 to 6 gram. Fatal period is 6 hours. The quinine serum level higher than 15 microgram per ml are indicative of serious toxicity. Early recognition of the visual damage is the essential feature to make the diagnosis. Eye changes include the photophobia, misty vision, usually begin in usually 1 hour of the toxic dose and may progress to partial or complete blindness in 6 to 12 hours. While such blindness may resolve over a period of time around 1 to 3 weeks, however, sometimes it becomes permanent. The management for the quinidine toxicity includes the general resistive measures, that is the general for all the poisons, that is A, B, C, D, and then the stomach wash with the prior endotracheal intubations should be undertaken only if the patient is seen within 1 to 2 hours of the ingestion. We already talked this that the indication of the gastric lavage is only when the patient presents immediately after the ingestion. Then activated charcoal may be beneficial and can be administered in the usual manner in the dose of 1 gram per kg. While acid diuresis promotes the clearance of the quinine and quinidine, it is associated with cardiotoxicity and so it is not recommended. On the other hand, serum alkalinization with the sodium bicarbonate can be beneficial. It is desirable to achieve and maintain a serum pH of around 7.45 to 7.50. Basically, the management in the quinine toxicity is the symptomatic. For the hypotension, the pure or predominant alpha agonist may be more effective in managing hypotension. These includes noradrenaline and methaminol. Continuous cardiac monitoring is essential. Alkalinization of serum prevents conduction abnormalities and arrhythmias. Treat QRS widening and ventricular arrhythmia with IV bicarbonate solution. A reasonable starting dose for the bicarbonate is 1 to 2 milliequivalent per kg as an IV bolus. Repeat as necessary to maintain the arterial pH in the range of 7.45 to 7.55. Then ventricular tachycardia or fibrillation can be corrected by direct current cardioversion. Torsade de pointis may be tackled with the magnesium sulfate, isoproterenol or overdrive pacing, while transvenous pacing is useful for the complete heart block. Refractory bradycardia or heart block that comprises blood pressure requires temporary pacemaker insertion. Correction of acidosis, electrolyte imbalance and hypoxia are imperative for successful management of cardiotoxicity. Then for convulsion, attempt initial control with the benzodiazepines that includes diazepam or the lorazepam. If convulsion persists or recur, then administer phenobarbital. Evaluate for hypoxia, electrolyte disturbances and hypoglycemia. Visual damage may be minimized by the stellate ganglion block, but there appears to be some controversy regarding this. Vision usually improves with prompt reversal of systemic toxicity. Though pupils remain dilated for a long time, even after complete restoration of the eyesight. Hemodialysis combined with resin hemoperfusion may help in eliminating quinine from the blood. Exchange transfusion doesn't appear to be beneficial. Then, on the autopsy, the organs are congested. There is no very specific finding in the patient. Red cell hemolysis may be seen. Kidney may be showing the blockage of the renal tubule due to hemoglobin, and papillae may be swollen. Engorgement of the peritubular capillaries may be seen. They all will be seen on the microscopic examination. Liver will show the fatty change. Rest all organs will not have any characteristic finding. Viscera shall be preserved for the toxicological analysis as routinely done. Similar to the other cardiac toxic plants and the cardiac poisons, here the clinical findings and the history, so the circumstances will be very helpful in making the final diagnosis for the patient. Then the medical legal importance for the quinine poisoning includes, in case of poisoning is usually accidental due to overdose. Suicide is rare with the quinine plants, and homicide is very difficult because of the bitter taste of the plant. However, it may be mixed with the alcohol and can be given to commit the homicide. It can be used as abortifacient as well, as it is an ecbolic, that is producing uterine contraction. Quinine is often found in the urine of patients who drink gin and the tonic. There is an interesting story of the presence of arsenic in the gin and the tonic. In the 19th century, malaria was endemic in India. The Britishers stationed in India needed quinine to prevent the malaria. Since quinine is soluble in very small quantities of alcohol, they would dissolve it to the gin they drank, and to mask the bitter taste, they would use it along with the lemon or the lime. This was the gin or tonic. Tonic because quinine preserves health by preventing malaria. By tradition, tonic water still contains small amounts of quinine, although the intention now is never to prevent the malaria. It is simply the preservation of the tradition. Quinine fluoresces under the ultraviolet light. To confirm the presence of quinine, gin containing tonic water glows blue in bars having the UV lights. Recently, during the COVID pandemic, it was said that quinine is able to protect from the coronavirus. So, it was consumed in a large quantity all over the world during this COVID pandemic period. The side effect of it may be there, but still it has not been much reported in the literature. Then coming to the aconite. Aconitum, aconite, blue rocket, devil's helmet, helmet flower, leopard's band, mitha bic or mitha wish, mitha jahar, monk suit, wolf's band, woman's man are all the names of the aconite plant. Aconite belongs to the genus of buttercup family, that is Ranunculaceae. During the ancient time, aconite was a common poison in Asia and Europe. It was a medicinal drug, a homicidal agent, and an arrow poison, all rolled into one. The death of Jewish high priest Alkimos in 159 BC was regarded as a stroke related. He died immediately after the collapse and the loss of speech. He collapsed and loss of speech followed shortly by his death. However, the description of severe pain suggests the aconite poisoning. So prevalent was the use of Aconitum napellus in the Roman Empire that the Emperor Trajan eventually banned the growing of this plant in all the Roman domestic gardens. This was the period around 98 AD to 117 AD. Roman poet Ovid around the 43 BC to 18 AD referred to aconite. Roman poet Ovid in around 43 BC to 18 AD referred the aconite as the stepmother's poison because it was used commonly by stepmothers to clear their hiring, because it was used by the stepmothers to get the inheritance of the property to his own childs. The manner of death of the Roman Empire Claudius in 54 AD was consistent with some of the clinical effects of the acute aconite poisoning. His spouse Agrippina was suspected to assassinate him. There are over 250 species of Aconitum, but most common are Aconitum napellus and Aconitum ferox. It is a perennial herb that grows in the Himalaya in the India. It grows 2 to 6 feet in height with palmate leaves, that is leaflet radiating from the base of the leaf. As you can see here, the plant that has the purple flowers and the leaves are radiating from the stem like a palm plant with outstretched fingers, and it has tuberous root that, as you can see in the picture. The poisonous plant of the aconite are all the plant's parts are the poisonous, but the roots are the most poisonous part of the plants. Dry root of aconite is about 5 to 10 centimeter long and 1 to 2 centimeter thick. It is dark brown in color. On cutting, it is white on inside and which becomes pink on exposure to air when dried. It is odorless while sweet in taste initially, later acrid in taste. Physically, root of aconite is arced, shriveled and shows longitudinal wrinkles, scars and bases of broken rootlets, conical and tapering. It is often mistaken for horseradish due to its appearance. Horseradish is also known as Baramasi or the Mulli. Horseradish has certain medicinal uses, so accidental poisoning with aconite is possible, thinking it as horseradish. To differentiate aconite root with horseradish, you can see from this table the appearance. This is the appearance of the aconite root, whereas the horseradish is cylindrical and the longitudinal in shape. The size of aconite root is conical and short, whereas the root of the horseradish is long and cylindrical. External color is dark brown, that for the aconite. Then for horseradish, it is yellowish white. Color on cutting that will be seen is whitish in case of aconite, whereas it becomes pink on exposure to air. Horseradish also has the white color and it doesn't change the color on exposure to air. Then the taste of the aconite is initially sweet and later it is acrid, whereas the horseradish is pungent in taste. By this we can differentiate the root of aconite and the roots of horseradish. Active principle in the aconite is the mainly C19 and C20 diterpenoids ester alkaloids that contains the aconitine, mis-aconitine, hypa-aconitine, jesa-aconitine, une-aconitine and other alkaloids like aconine, bica-aconitine, inda-aconitine, lapa-aconitine, picra-aconitine, pseudo-aconitine. The mechanism of action of the aconite is similar to the other cardiotoxic poisons. It basically causes the sodium channel activation in the cardiac system. Aconite alkaloids opens up the sodium channels that increases sodium influx through them, resulting in increased inotropy while delaying the final repolarization phase of action potential that promotes the premature excitation of myocardial muscles. As a consequence of repeated depolarization, the sodium channel becomes refractory to excitation. Aconitine also acts on nerve axons by opening the sodium channels. It also stimulates the vagal medullary centers and by this inhibits the cardiac system. Then under the toxicokinetics, it is absorbed through all the roots and it is mainly eliminated through urine, but it may be eliminated through other routes as well. Fatal dose for aconite is, for the root of the aconite it is 1 to 2 grams. The whole plant it is 1 gram. The aconite is 2 milligrams. The extract of aconite it is 250 milligram and fatal dose for tincture is 5 ml. Fatal period of aconite poisoning is 2 to 6 hours. Then coming to the clinical features of the aconite poisoning, when it is ingested or applied through other than the ingested root, then when eyes are exposed to the pollens of the aconite plant, it can cause pain and swelling of the eyes. When leaves or the root are handled for the long time or rubbed on the skin, it causes numbness and tingling sensation on the contact parts. On inhalation of the root, if it is inhaled for the long time, it produces narcotic effect. Then on ingestion of the aconite root, symptoms appear immediately or within a few minutes. The initial symptoms are on the gastrointestinal tract that presents with a burning sensation from the mouth to the stomach, numbness, tingling in the mouth, tongue and the pharynx, salivation, nausea, vomiting, diarrhea, and in the later period the mouth will be dry, thirsty and the dysphagia may be presentation. Cardiovascular system will present with the ECG and the rhythm changes, atrial and ventricular arrhythmias, resistant to electric defibrillator will be seen, AB block, bundle branch block, ectopic beats, tachycardia followed by the bradycardia, torse de pointis may be present in the patients, ventricular ectopics may all be there as the cardiac manifestations. Then the patient will present with the hypotension, slow and feeble irregular pulses. On respiratory system, feeling of the constriction in the chest, respiration slow, labored and the shallow. On the central nervous system, the effects are limited. Consciousness of the patient will be clear. Sometimes there may be hallucination, headache and giddiness, numbness and tingling sensation over all the parts of the body and the restlessness and vertigo. In the muscular system, the weakness of the muscles with a spasm and twitching, shooting pain in the muscles, limbs become weak, patient unable to stand or walk, cramps and convulsions. On a skin, pallor will be seen on the skin, profuse sweating may be present, cold and clammy skin due to hypotension and hypothermia will be the manifestation. In the eyes, diplopia, that is double vision, and the impaired visions are the feature. Hippus is the unique feature of the aconite poisoning. Fluctuations in the pupillary diameter about 1 to 2 mm occur with a marked periodicity and then remain dilated in the later stage. Then hippus is an important feature of the aconite poisoning. It is often asked in exams as well that hippus is seen in which type of poisoning. So it is aconite poisoning, hippus is seen. In hippus, the pupils contract and dilate alternately. So the fluctuation in the pupil diameter of around 1 to 2 diameters occur with marked periodicity and then it remains dilated in the later stages. This is all features of the hippus. Then cause of death in case of the aconite poisoning is the ventricular fibrillation mainly. However, sometimes respiratory failure may also be the reason for the cause of death. Then for the management of the patient, basically the same resuscitative measures and there is no specific antidote for the aconite poisoning. So the prolonged resuscitation for the cardiac arrest is recommended. Prolonged resuscitation for the cardiac arrest is recommended following poisoning, as recovery with the good neurological outcome may occur by this. Then gastric decontamination shall be done. Gastric lavage with warm water and the weak solution of tannic acid or iodine in potassium iodide precipitates alkaloids. Also, charcoal is given after the gastric lavage. There is no specific antidote. Treatment is mainly symptomatic and supportive after decontamination. For bradyarrhythmia and hypersalivation, atropine is given. Then the ECG changes shall be noted and measure the QRS duration and QT interval. Magnesium sulfate shall be administered urgently to patients with the torse de pointis. Magnesium sulfate may also be given to patients with a prolonged QT to reduce the risk of torse de pointis. Arrhythmias are unfortunately often refractory to the drug management. No single antiarrhythmic agent has been found to be uniformly effective for controlling tachyarrhythmias. DC cardioversion is not effective. For symptomatic bradycardia, give atropine intravenously 0.5 to 1.2 mg for an adult or 0.002 mg per kg for a child. Repeat doses may be necessary. Dobutamine or isoprenaline may be considered if bradycardia is associated with hypotension. Temporary pacemaker insertion may be required. Alternatively, external pacing may be used. If cardiotoxicity is unresponsive to above therapy, then consider the use of lipid emulsion. In adults and children, the dose of the lipid emulsion is 1.5 milliliter per kg of 20% intralipid as an intravenous bolus, followed by 0.25 to 0.5 milliliter per kg per minute for 30 to 60 minutes. If cardiotoxicity is unresponsive to above treatment, then consider the use of lipid emulsion. The lipid emulsion is given in adults and children in the dose of 1.5 milliliter per kg of 20% intralipid as an intravenous bolus, followed by 0.25 to 0.5 milliliter per kg per minute for 30 to 60 minutes to an initial maximum dose of 500 milliliter. In patients with life-threatening hemodynamic instability, veno-arterial extracorporeal membrane oxygenation can be used. In one reported case of the aconite poisoning with severe aconite-induced cardiotoxicity, cardiopulmonary bypass and left ventricular assist device were found to be beneficial. So, all this may be done in the management of the patients with the aconite poisoning. Then after death of the patients, as the forensic examination on postmortem, there will not be any very characteristic feature. However, the mucosa, gastric mucosa will be congested and ecchymosed, stomach moiso presence of aconite root pieces, all the organs will be congested. Toxicological analysis is helpful in the diagnosis as aconite is extremely unstable and is destroyed by putrefaction. So, quick analysis is most important. So, the postmortem examination basically similar to the other cardiac poisons includes the proper history, clinical findings, clinical diagnosis and the lab reports and the postmortem examination followed by the toxicological analysis correlation. Then after the final opinion for the toxicological cases shall be given. Medical legal importance of aconite poisoning are innumerable. It is used as arrow poison. The name aconite itself derives from the word acon, that means the dark or the javelin. It is also used as cattle poison. For the purpose of suicide, it may be used. It has been reported in all the manners of death, whether it is suicide, accident or homicide. Once it was a very popular homicidal agent, but not very commonly used now. In India, traditionally, it was given with the betel leaves to conceal its taste. Occasional cases of homicide still occur with the aconite. Recently, John Henry Lamson was an American doctor who killed his 18-year-old brother-in-law, Percy John, a hemiplegic, in order to secure a share of the family inheritance. He visited his boarding school in 1881 and gave him a slice of Dundee cake spiked in aconite, and John died immediately afterwards. Lamson was tried in March 1882 and found guilty of murdering Percy. He was hanged on 28th April 1882. Another recent case is that of Lakhvir Kaur Singh. This case occurred in Britain on Jan 2009 when Lakhvir Kaur Singh, a 45-year-old married Punjabi woman and a mother of 3 children, mixed aconite which she brought from India in the food of her former lover 39-year-old Lakhvir Chema, former lover 39-year-old Lakhvinder Chema Lucky, and his girlfriend 29-year-old Gurjeet Chugh. On that day, she visited Lucky, went to his fridge and mixed aconite in his food. They were set to marry 2 weeks later on 14th February 2009, that is on the Valentine's Day. Lakhvir and Lucky had been lovers for 15 years, but when Lucky met Gurjeet, he decided to marry her. Lakhvir, whose husband was a cancer sufferer, could not bear the thought of Lucky marrying someone else. The lady Lakhvir, whose husband was a cancer patient, could not bear the thought of Lucky marrying someone else and poisoned their food on 27th January 2009. Next day on 28th January, both Lucky and Gurjeet consumed the poisoned food and immediately became violently ill. Both were rushed to the West Middlesex Hospital where Lucky died. Gurjit survived because she had eaten less amount. Police found Aconite in two bags in Lakhvir's coat and in one handbag at her home in Southall, West London. Lakhvir Kaur was found guilty and sentenced to 23 years in the prison. So, Aconite was once a very popular homicidal poison. As it is cheap and easily available, lethal dose is small, fatal period is short, taste is somewhat sweetish, and it can be made more acceptable by mixing it in the liquor or the pan. It gets destroyed by putrefaction, so its detection is very tough. That is all the features of an ideal homicidal poison. We already studied the features of the ideal homicidal poison. This is only naturally occurring plant poison that is in the category of ideal homicidal agent. This is usually mistaken for horseradish root, resulting in accidental poisoning. It can also cause abortion in pregnant women. It is often used by Quakes in India in the various herbs. There is an interesting mythological story associated with Aconite. Ancient Greeks thought that Aconite grew up wherever the saliva of mythical three-headed dogs, Cerberus, the guardian of hell, fell on the ground. You must have seen the three-headed dogs in many of the movies. It was supposed to be so toxic that it poisoned a person as he gathered it. Aconite was an important ingredient in magic and sorcery. It was supposed to be helpful in the treatment of lycanthropy. Lycanthropy is a legendary and anecdotal capacity of some human turning into the wolves. Various movies shows that a human turning into the wolves. That this phenomena is called lycanthropy. That is the legendary and anecdotal capacity of some humans turning into the wolves. So it was also fed to wolves, thinking that this wolves has been result of lycanthropy that resulted in death of that wolves. Hence the name wolf bane came to Aconite. It finds mention in the Harry Potter's book, which has magic and sorcery as their theme. It may also cause inadvertent poisoning if used for sorcery. This is all for the cardiac poisons. Thank you. Best wishes.